All right, let's talk about one of the most fundamental skills in medicine, figuring out a heart murmur. Honestly, think of it like you're a detective. Your stethoscope is your magnifying glass, and that little whooshing sound, that's your first clue. We're going to walk through how to take that clue and follow the evidence step by step all the way to a diagnosis.
So picture this. You've got your stethoscope on a patient's chest. You're expecting to hear that nice, clean love-dub, but you hear something else. A little whoosh, maybe a rumble. And for a second, you might think, uh-oh, what's that? But that's not a moment for panic. That's where the real work begins. That sound is your lead. So what's your next move?
First things first, before we can analyze it, we have to know what it actually is. A heart murmur isn't the disease itself. It's just a sign. It's the sound of blood moving in a way it's not supposed to. And our job is to figure out the why.
It all really boils down to one thing: turbulent blood flow. Just imagine water flowing really smoothly through a clean pipe. Now what happens if you squeeze that pipe, or if the pipe wall is all bumpy, or if there's a leaky connection? You'd hear it, right? It'd get noisy. That's exactly what's happening in the heart. Whether it's a stiff valve, a leaky one, or just way too much blood trying to get through, you get turbulence. And that turbulence is the sound we call a murmur.
Okay, so with any good investigation, you have to start with the most important question first. And for heart murmurs, that question is all about timing. When is this sound happening? I'm telling you, nailing the timing is the single most important thing you can do. It immediately slashes your list of possibilities in half.
To get the timing right, we need our landmarks. Those are the normal heart sounds. You've got S1, that's the lub, when the bottom chamber valves slam shut. And then you have S2, the dub, when the top chamber valves close. That space between the lub and the dub, that's systole, when the heart is squeezing. And the space after the dub and before the next lub, that's diastole, when the heart is relaxing and filling up. Every single murmur happens in one of those two windows, period.
And here's the absolute money takeaway. You have to figure out, is the murmur happening between the lub and the dub or after the dub? If it's systolic, between S1 and S2, it could be harmless or it could be a big deal. But if it's diastolic, that is a huge red flag. A diastolic murmur is almost always a sign of a problem. Just by figuring out the timing, you've already learned a massive amount about the patient's risk.
And you can see it so clearly right here. Look on the left. That murmur fills up the entire gap between S1 and S2. That's systolic. Now look at the one on the right. See how the sound doesn't even start until after S2? That's a diastolic murmur. The difference is pretty stark when you see it like this. And trust me, with practice, your ears will learn to hear that distinction just as clearly.
Okay, we've nailed the timing. That's huge. Now we can start building a more complete profile of our suspect, if you will. We need to describe this thing in detail. What does it actually sound like? Where's it loudest? How loud is it? So we're going to focus on three main characteristics. Number one, intensity, which is just how loud it is. Number two is its shape, how the loudness changes from beginning to end. And number three is location, the exact spot on the chest where it's the loudest. Each of these clues is going to get us one step closer to solving the puzzle.
Now, intensities is graded on a pretty simple 1 to 6 scale. A 1 is super faint, a 6 you can hear without the stethoscope even touching the chest. But here's the real clinical pearl. Once you get to a grade 4, the murmur is so loud that the turbulence is literally causing a vibration you can feel with your hand on the chest wall. That's called a thrill. And if you can feel a thrill, you know you're dealing with something significant.
All right, let's talk about shape, because the shape of the sound tells a story about what's physically happening. Take a look at this one, a crescendo-decrescendo murmur. It gets louder, then it gets softer, making this classic diamond shape. This is what you hear when blood is being squeezed through a tight opening, like a stiff aortic valve in aortic stenosis. The sound gets louder as the pressure builds, and then fades as it falls. It's beautiful, really.
Now contrast that with this. This is a hollow systolic murmur. See how it's just flat, like a plateau? It stays at the same intensity all the way from S1 to S2. This suggests there's a constant pressure difference between two chambers, which is exactly what you get when a valve is leaky, like in mitral or tricuspid regurgitation. Again, the shape of the sound perfectly matches the physics.
And here's a great diastolic example, a decrescendo murmur. It starts loud right after S2 and then just kind of fades away. This is the classic signature of aortic regurgitation. It's the sound of blood leaking backward from the high-pressure aorta. As that pressure difference gets smaller and smaller during diastole, the murmur just gets quieter and quieter.
So we've got timing, intensity, shape, and location. We're building a pretty strong case.
But what if things are still a little murky? Well, now it's time for the interrogation phase. We can use simple bedside maneuvers to change the blood flow in the heart, and that change can force a murmur to reveal its true identity.
Let's look at two of the most powerful ones. First is the Valsalva maneuver. That's when you have the patient bear down. This makes it harder for blood to get back to the heart, so venous return goes down, and most murmurs get quieter. Squatting does the exact opposite. It shunts blood back to the heart, so venous return goes up, and most murmurs get louder. But the real magic is in the exceptions. There are two famous murmurs that do the complete opposite, HOCM and mitral valve prolapse. They get louder with Valsalva and softer with squatting.
And this is why it matters so much. HOCM and aortic stenosis can sound really, really similar, but HOCM is a condition that can cause sudden death in young people. Being able to tell the difference right there at the bedside just by having the patient squat, that is a critically important, potentially life-saving skill.
So, at this point, we've gathered all our clues. We have the timing, we have the character of the sound, and we have its response to our interrogation. Now it's time to put it all together and solve the case. A flowchart like this one shows you exactly how to do it. Let's just walk through an example. Say you hear a holosystolic murmur. Okay, the main suspects are mitral regurgitation, tricuspid regurgitation, or a VSD. So where do you start? Location. If it's loudest at the apex, you're thinking mitral. If it's down by the lower left sternal border, it could be tricuspid or a VSD. So what's the tiebreaker? Have the patient take a deep breath in. If the murmur gets louder with inspiration, that points to a right-sided problem, like tricuspid regurgitation. See? You just follow the clues.
Your physical exam is an incredibly powerful tool. It really is. But even the best detective knows when to call for backup. So the last step in our approach is knowing when your investigation needs the definitive test, an echocardiogram.
And the guidelines for this are actually pretty clear. Remember how we said diastolic murmurs are almost always a problem? Well, they always get an echo. Same goes for holosystolic murmurs. For those other common murmurs, the mid-systolic ones, you get an echo if they're loud, like grade 3 or higher, or if your patient has any symptoms that could be related, like chest pain or shortness of breath. It's a system to make sure we investigate the high-risk situations without overtesting everyone.
So there you have it, a systematic approach, a framework you can use to turn a confusing sound into a clear, logical diagnosis. So the next time you're on the wards and you hear that little whoosh, you'll know exactly what to do. You'll know that the first and most important question to ask yourself is it happening in systole or diastole?